Greetings. So this video, we will talk a little bit about the histamine drugs. So these are drugs that act on histamine, right? So we talked about the histamine cytokine in the anatomy and physiology portion of this when we were discussing immunology, right? Remember that? If you haven't watched that video, I want you to watch it because if you do, uh, if you know anatomy, physiology, pharmacology, and pathology becomes very easy. In fact, 70 to 80% of the information makes perfect sense. So make sure you review that video. Um, I'll just do a quick overview. So essentially, we talked about histamine being pro-inflammatory. So it increases inflammation. We talked a little bit about mast cells and IgE and degranulation, which leads to histamine production. We also talked about how histamine causes symptoms of inflammation. Okay, so we talked about all of this stuff in those videos. So I want you to review that video. Uh, let's continue from that video. So when histamine is released, it acts on receptors, and guess what those receptors are called? Histamine receptors. And there's different kinds, but there's two that are very, very important and that we're going to talk about. It's H1 receptor and H2 receptor. Now, the H1 receptor has a role in allergy and allergic response. So remember we talked about histamine and how it causes inflammation. And again, allergy, and allergic rhinitis and atopy and asthma and some of these diseases are related to inflammation. Um, and that has a component of histamine that's acting on these H1 receptors. Um, so that's a very important thing to know. So that's the H1 receptor. H2 receptor in the stomach causes acid secretion. We have our stomach, and there's hydrochloric acid that's produced in there. And H2 receptor has a role in that function. So again, just a quick review. When did we release histamine? So remember type 1 hypersensitivity with antigen B cells producing antibodies attaching to the mast cells, and now the system is primed. So when the drug comes in again, boom, the mast cells regranulate. You have histamine that acts on H1 receptors. And then you have tissue injury, which causes the mast cells to degranulate. So that's another pathway. And then again, there's drugs and toxins that may cause hypersensitivity as well. Okay. So again, these were some of the physiology things we talked about. Uh, Again, with H1 receptor, that's one of the important ones, along with H2. Uh, when histamine acts on it, you start to see symptoms of inflammation. So again, when we looked at the video, we talked about capillary dilation, which leads to more blood flow, hyperemia. More blood flow equals heat. There's more capillary permeability. So again, now you have fluid that seeps out, so there's swelling. Um, Again, it activates pathways that causes pain. There's smooth muscle constriction, for example, in the lungs. There's itchiness in the skin. So again, these are some of the things that this receptor does when stimulated by histamine. The other receptor is the uh, H2 receptor in the stomach. So the parietal cells in the stomach, so here's H2 receptor, that gets stimulated. And what it does is it positively stimulates production of proton, which is the hydrogen ion, which is also called a proton, and it pumps that proton into the lumen of the stomach. And because it's positively charged, it takes away one potassium uh, particle or ion so that the charges are balanced out. Okay, and so this pump which pumps hydrogen ion or proton into the stomach lumen is proton pump. And the role of the H2 receptor is it has a positive effect on this mechanism, and it causes, so H2 stimulation causes increase in hydrochloric acid in the stomach. Okay, so that's the physiology for the H2 receptor. So again, let's recap the physiology because then the pharmacology will make sense. So mast cells plus IgE plus allergen gives you histamine, which acts on the H1 receptor and gives you symptoms of allergy. So if I block the H1 receptor, what would happen to the symptoms of the allergy? They're going to go away. Easy, right? Hey, I block this. Symptoms go away. What if I prevent the mast cells from degranulating? Well, that's not going to produce histamine, right? And going to take away the allergy too. So that's the other mechanism. I can stabilize the mast cells, so there's no degranulation. No degranulation means no histamine. That means less allergy symptoms. Okay. If I block the H2 receptor, so remember the H2 receptor gives us hydrochloric acid in the tummy. There's going to be less hydrochloric acid in the stomach. And these are the drugs we are going to talk about. Drugs that block the H1 receptor, so they'll have decreased symptoms of allergy. Drugs that stabilize mast cells, they're going to prevent degranulation of mast cells and prevent allergies. And then blocking of the H2 receptor, which is going to decrease the acid. So that's what we're going to talk about next. So let's take a peek at our next step, which is our drug map. So here's the histamine drugs. Okay, so the first thing we're going to talk about is the H1 receptor blocker. Aha, it's this one here. Exactly what we're going to talk about, and it's used for management of allergies. Now, there's two generations of these H1 blockers, and we separate them out because they're a bit different. There's the first generation, and guess what the second one is? Second generation. Yes, has got it. So, H1 receptors, you have the older generation, which is the first generation, and then you have the newer generation, which is the second generation. Okay? So that's what we're going to study first. We're going to talk about H1 receptor blockers, which are divided into first generation and second generation. They're used for allergies and allergy symptoms and atopy. So let's talk about the first generation H1 blockers. So they came to the market first. That's why they're first generation. They were also lipophilic. So in other words, they would dissolve in fat. They liked fat. And thus they were able to cross the blood-brain barrier. And because of that, they have a lot of central nervous system effects. It's really, really important. Okay? Now, because they crossed the blood-brain barrier, they had more CNS effect or central nervous system effect. So remember that. So what are some of the drugs? There's diphenhydramine or Benadryl. That's the prototype drug. Okay? And then you have Phenergan or Promethazine and Meclizine. So these are three big, common, useful drugs. Okay, so what are they used for? Right off the bat, H1 receptor blockers. What do you think? Allergic symptoms. Okay, that's what they're used. Now, the allergies can be mild seasonal allergies, rhinitis, itchy eyes, itchy nose, mucus going down the back of the throat. So it could be mild. Could be severe, for example, anaphylaxis and anaphylactic shock, which are very, very serious and life-threatening. And they're used for the spectrum. Okay. Now, the other interesting thing is because these drugs have CNS effect, or central nervous system effect, we can use these drugs to do some of these things in the central nervous system. For example, if somebody has motion sickness, we can give them some of these drugs and that can address it. If somebody can't sleep, we can give them this drug, but some of these drugs, and they can go to sleep easier. Again, if there's nausea, vomiting, these drugs can assist with that as well. That's because they act on the central nervous system as well. They have some central nervous system effects. That also means that they have some central certain nervous system side effects. So in other words, remember insomnia? So some of these drugs may cause somebody to fall asleep more easily. But what else does that mean? Well, that means that these drugs are more prone to sedation. So we'll talk a little bit more about it in detail in just a second. Okay, let's take a look at a nice chart which actually really helps me when I'm studying these drugs. And I think it'll help you as well. Okay. Let's just center this just a bit, okay? So essentially, these are the meds. So I have the diphenhydramine, Benadryl, meclizine, and promethazine, okay? Again, all these drugs, first generation H1 receptor blockers, have a cholinergic effect, okay? And you'll study more about this when you study autonomic nervous system drugs. So for now, dry mouth, urinary retention, um, these are some of the things that one experiences with these drugs. Uh, so that's one classification. The other thing that these drugs do is they interact with the serotonin in the brain, causes sedation. Okay, and then they also act on the anti-motion or the motion aspect in the brain, um, which also helps with the motion sickness. So Benadryl, the prototype drug, you have dry mouth, urinary retention. You also have sedation, and it's got good anti-motion effect. Meclizine doesn't have as much cholinergic and sedative effect, but it has a huge amount of anti-motion effect. So guess which drug is used for motion sickness a lot of times? Meclizine. Excellent. And then promethazine, again, if you see, there's the cholinergic, serotonin, and anti-motion. So it's not as good for anti-motion, but it's used for nausea and vomiting. So it's one of the drugs that's used for nausea and vomiting. So again, these drugs used for allergic symptoms, for sedation, meclizine is used for anti-motion, and promethazine is used for nausea and vomiting. So these are the uses. You guys know how they work, right? Block the H1 receptor and prevents the symptoms. Okay. Is it working? How do you know? Well, I got allergies. I'm taking drugs for it. So symptoms are better. It's working. Insomnia. How do I know it's working for insomnia? Symptoms are better. I can sleep. Motion sickness. How do I know it's working? Well, I take meclizine and I don't have motion sickness. Nausea and vomiting. How do I know it's working? Well, the patient complains of less nausea or no nausea, and as a nurse or a healthcare provider, I don't see them vomiting. Symptoms are better. Side effects. Remember we talked about sedation? Yes, yes. Now this is where we do some critical thinking. So remember, let's see where the stories, let's put sedation in an elevator with alcohol. What does alcohol do? Sedates you. What does Benadryl do? Sedate you. So if I put the two of them in an elevator, what do you think they'll talk about the most? Sedation. So when somebody's talking about taking this medication and then they also drink alcohol, what comes to your mind? Uh-oh, this person's going to be sedated big time. I don't want that. Okay? If I taking a drug and I'm operating heavy machinery, that's not good. I can harm myself and other people. What do I need to educate the patient on? Do not operate heavy machinery. What about if I take morphine or if I'm taking some drugs, right, which cause sedation, and then I take Benadryl? Sometimes morphine causes itching. So here it is. I give patients morphine for pain. They're itching. There's an order for Benadryl. I give them Benadryl. Well, morphine, sedation, Benadryl, sedation. Put them in an elevator. What do you think they're going to talk about? Sedation. They're going to sedate the patient, right? So here you go. We're now starting to critically think. We're putting together what morphine does, what alcohol does, with what this drug is doing. Okay? Dry mouth. Remember the cholinergic effect? So, what can I do for it as a provider? Encourage more fluid, suck on sugarless candy. Okay? Urinary retention. So, again, what can I do? Again, educate the patient and monitor them for urinary retention and input and output. Now, let's talk about some critical thinking here. So, if I have an older gentleman with a prostate that's big, benign prostate hypertrophy. They're prone to urinary retention. So I put BPH in the same room or in the same elevator with Benadryl. What do you think they'll talk about? Sedation? Sure. But what they're going to talk about more is urinary retention, right? Critical thinking. I got to be very, very careful about urinary retention in these patients. Some fact to know about paradoxical reactions. So, what does this drug do? Sedate most of the people, but in some children, creates paradoxical reaction. These kiddos become very excited, agitated with Benadryl. So that's a idiosyncratic reaction. That's a reaction which is different from how it acts with most of the population. So, and again, it's paradoxical because it doesn't make sense. It's against intuition. It's against what we know. So that's why it's paradoxical. So again, that's what this drug uh, can do to some kiddos, okay? Especially children. You see this in them. Okay, so we talked about the H1 receptor blockers and we talked about the first generation. Well, let's talk about the second generation, the newer ones, the newbies. Okay, so they are not lipophilic, so they don't have as much CNS effect or central nervous system effect, and they're more H1 receptor specific. So right off the bat, what does that tell you? Well, the side effects and the good effects that we had for these drugs related to their CNS, central nervous system, is not there. So there's no good and no bad because they don't work on that aspect. Okay? And I think it had to do more with sedation. Take these drugs and you're drowsy. So here I am with allergic rhinitis. I got to go to work and I'm sleeping all day. So that's why these drugs came to the market. That's their gap, market gap. Let's look at some of the drugs. Loratadine, that's Claritin, cetirizine, Zyrtec, fexofenadine, Allegra. So these are the three drugs. Claritin is usually the prototype. Okay. What's the use? Allergic rhinitis. They don't have any CNS or central nervous system use. Same table. As you can see, all the other effects are hit or miss. Cetirizine makes you a bit more sedated, but the other symptoms are plus or minus. How do you know it's working? Well, we give it for allergic rhinitis. If symptoms are better, it's working, right? That's it. Easy peasy, right? Okay. Now, let's spend some more time on the next drug, which is the mast cell stabilizer. So remember the drugs where they stabilize the mast cells and prevent them from degranulating. They don't degranulate, no histamine, no histamine, no symptoms. Okay, so that's what we're going to talk about. Drugs, cromolyn, nidocromil. And these are, cromolyn is the prototype drug. Mechanism of action, I think we've talked about that one. Its use, allergy, asthma, and atopy. Atopy is what? Atopy is basically a predisposition to these allergic symptoms. Allergic rhinitis, asthma, food allergy. So it's like a trifecta. And then you have these skin conditions with dermatitis. And it's got to do with exposure to a certain allergen that's triggering this hypersensitivity. Okay? And that's atopy. But that's what the drug is used for. Asthma and allergy are the two big ones. Is it working? If I have allergies and I'm giving it for allergies, well, symptoms of allergy should be better. If I'm giving it for asthma, well, how's the asthma doing? Are there less acute attacks? When we wake up every day, how's the flow, the expiratory flow? And how's the lungs? How are they sounding? So again, asthma assessment, and is it trending better or not? It's actually pretty safe. The big thing to understand and educate the patient on is it is not used for rescuing for an acute asthma attack. So if they're having an acute asthma attack, this is not the drug to give. This is not the drug to give. They get the bronchodilator, which is a beta 2 agonist, but they don't get cromolyn or these drugs for acute management. It's for chronic management or long-term management of asthma. Okay? And we'll talk more about asthma when we look at pathologies. From a drug perspective, again, it's used for prevention of asthma. Chronic maintenance for asthma is what it's used for. Okay, so that's mast cell stabilizers. Just a quick note, this is a special mention. Okay, so remember the two mechanisms, mast cells plus IgE plus allergen gives you histamine plus H1 receptor gives you symptoms. Well, what if I have drugs that combine the blocking of the H1 receptor and that also have a mast cell stabilizer in there? Well, these would be amazing because not only would you stabilize the mast cell with one drug and prevent them from degranulating, if there are a few mast cells that do degranulate and they try to get and stimulate the H1 receptor, they'll not be able to. So we are synergizing here. Okay. Well, guess what? Yes, we do have a couple of medications. These are nasal sprays that actually do that. Azilastine and olopatadine. Okay, these are a couple of medications that are combination drugs. H1 receptor blockers and mast cell stabilizers. Okay. So we covered what? We covered H1 receptor blockers first generation, H1 receptor blockers second generation, mast cell stabilizers, and combination of second generation H1 blockers and mast cell stabilizers. Okay. Last but not the least is the H2 receptor blocker. So let's talk about that. How do they work? We've talked about it. They prevent H2 stimulation and thus decrease the hydrochloric acid in the stomach. Drugs, ranitidine, famotidine, cimetidine. Ranitidine, famotidine, cimetidine. Ranitidine or Zantac would be the prototype drug used to decrease acid. When do you decrease acid? When there's too much. What are some of the pathologies where there's acid that is causing damage where we want to reduce acid? GERD, gastroesophageal reflux disease. PUD, peptic ulcer disease. Zollinger-Ellison syndrome, ooh, big stuff. Essentially, it's a syndrome where there's too much acid being produced. And we can go on and on and on and on and on. There's several conditions where we want to reduce the acid in the stomach. And we may consider, the provider may consider using this classification of medication for this purpose. Is it working? Well, if I'm giving it for gastroesophageal reflux disease, are the symptoms of acid getting better? They are, it's working. Peptic ulcer disease, is the dyspepsia better, right? So again, that's one of the things that we can assess. Side effects, again, you have headaches, like you have with everything. With cimetidine, there is more drug in side effects. So this, even though they're very safe, uh, generally compared to some of the other drugs, a safer profile. Cimetidine in particular has more drug side effects, and it's androgenic. So again, males may have gynecomastia. What does that mean? Enlarged breast tissue in males, and it may inhibit prolactin, or it has some it interferes with prolactin. So again, it may have the males may have or females may have galactorrhea, or that is milk coming out of the breast, even though it's not physiological. Okay, so that's kind of some of the side effects. Uh, Critical thinking. Let's think about it. Let's say somebody has heartburn. What do? I go to the store, I pick up Tums, I pick up Zantac, because a lot of these medications are over the counter. I pick up, other drugs, and then do what? I take all of them, right? Because I don't know what these drugs are doing. So if I take calcium carbonate or Tums, what happens? Well, it's an antacid, but it can interfere with the absorption of this H2 blocker. So even though I'm taking 2 meds, it's not able to synergize because this drug has to be absorbed in the blood and then go to the H2 receptor through the blood. But if the other medication that I'm taking is preventing its absorption, it's not letting it absorb and synergize and do its job. So actually, it works against it. So again, some of the things to think about. Sometimes you see that on the test with critical thinking. So I do want to make sure I kind of share this with you so that it's on your horizon. So let's just go through this again. Histamine drugs, two receptors, H1 and H2. H2 receptor is important for allergy. H1 receptor is important for allergy. H2 is for acid. Remember, mast cell plus Ig plus allergen gives you histamine, which connects with the H1 receptor, gives you allergy symptoms. If I stabilize mast cell, I don't get histamine. Mast cell stabilizers. If I block H1 receptors, even if I get histamine, it's not going to be able to stimulate H1, so allergy symptoms are going to go down. Okay, if I block both, amazing, I synergize. Okay, and then again, H2 receptor decreases the acid in the stomach. Okay, histamine drugs, two of them, the classification is two generations, which is the older generation, which is first generation, and second generation. Big difference is CNS effect with the first generation and no CNS effect with the second one. Again, the first generation one, because of the CNS effects, are used for motion sickness, insomnia, nausea, vomiting. You have diphenhydramine, meclizine, promethazine. Meclizine is more anti-motion. Promethazine is nausea, vomiting. Benadryl you can use for insomnia and general allergic symptoms. Uh, and then we talked a little bit about some of the side effects with sedation, dry mouth, urinary retention, and paradoxical reaction, and did some critical thinking. Again, as far as the second generation is concerned, it's just allergic rhinitis, and we looked at loratadine, cetirizine, fexofenadine. Okay, so that is classification one. And then we looked at mast cell drugs. Okay, mast cell stabilizers, so cromolyn, and again we looked at its use for chronic or long-term management of asthma, allergy, and its safe profile generally. Just to remember, it's not used for emergent acute asthma attack. And then combination drugs with nasal sprays, which combine function of H1 blocking and mast cell stabilizing. For H2 blockers, it's ranitidine, famotidine, cimetidine, decreases acid, and then cimetidine has a lot of drug side effects, kind of fallen out of favor a little bit, and but generally very safe profile. And we are looking at headache being the number one issue with these drugs.